Alright, so today we're going to do the second part of this acid base balance lecture. And believe me, this is not the last time you're going to hear about this. You'll be hearing about this through the rest of the program. So you'll be exposed to it many times and it'll finally get there. So moving on to the next slide here. Alright, so before we were talking about the bicarbonate and the non-bicarbonate systems, the open and closed systems. So those are our immediate defense against that accumulation of the hydrogen ions. Okay, so if we get too many hydrogen ions, remember that's where we get into an acidosis. Okay, so if the acids, if we couldn't get rid of them, then we would be in a life-threatening acidosis. So that's where we would definitely need to intervene. So, so we're looking at the lungs at excreting our CO2. Huge amounts of CO2 are produced during aerobic metabolism, and that's generally what's going on in our body. We remove approximately 13,000 to 24,000 millimoles per liter daily. Okay, I know those are huge numbers. So because the volatile acid, carbonic acid, is in equilibrium with dissolved CO2, the lungs then help decrease that carbonic acid concentration through ventilation. The elimination of CO2 is crucial, obviously, because normal aerobic metabolism again produces large quantities of CO2, and CO2 plus water leads to the formation then of large quantities of carbonic acid. I think I have a typo here. Oops. Hold on, I got two mouses going here. Hold on one second. Alright, so we're going to talk a little bit about kidneys. So kidneys physically remove the hydrogen ions from the body. They actually, though, excrete less than 100 milliequivalents of fixed acid per day, which is really a small amount compared to the lungs. So the lungs are the ones that do most of the work of getting rid of the hydrogen ions. The kidneys control the excretion and the retention of bicarb. Okay, so that HCO3 is your bicarb. Okay, so I'll just be saying bicarb instead of the letters. So so your kidneys then are in charge of your bicarb. So when you think of CO2, again, you think of lungs, and when you think of bicarb, you think of kidneys. Okay, so if blood is acidic, more hydrogen ions are excreted, and all the bicarb then is retained. So we're trying to get that, the bicarb then is our buffer to all the acid, basically. Okay, so it helps kind of keep that balance going, right? And vice versa. So if we have a high bicarb level, okay, so it's really complicated to explain at this level, but over time, for example, for like COPD patients, smoker patients, they chronically will have a higher CO2. Okay, they just live there at that high CO2. Their lungs don't get rid of the carbon dioxide as efficiently as a non-smoker, over a period of time, over years, and they start retaining. So we call them retainers. They actually retain CO2. And normally those higher levels of CO2, if we were to experience that, just meaning, I guess myself being a non-smoker, or a healthy individual that doesn't smoke, if we had those higher CO2s, that would really mess up our pH. But over time, and it takes months, years, that the kidneys end up compensating, and then they, to help offset that acid from the high CO2, they offset it by retaining bicarb, because bicarb then is a buffer. Okay, when bicarb is low, for example, like in a metabolic acidosis, metabolic meaning that the kidneys are the reason, or some other metabolic process, but we kind of differentiate between respiratory and metabolic conditions. So metabolic generally is kidney. A lot of our renal patients, renal failure patients, diabetics, they're more prone to renal disease. They will kind of chronically have a lower bicarb level, especially if they're on dialysis. So they're particularly and then they may have a little bit higher respiratory rate because the low bicarb and the high CO2 is what creates the acidosis. And depending which is going on, if it's the bicarb or the CO2, that's how we differentiate kind of whose fault it is, basically. Okay, enough said. I don't want to get into it any deeper than that. So lungs do remove greater quantities of fixed acid than compared to kidneys. So again, in healthy people, that acid excretion mechanisms of the lungs and the kidneys are very delicately balanced. Okay, and so when people are ill or have a disease process going over, failure of one of those systems can be generally partially offset by a compensatory response from the other system. But a lot of times people have multi-system failures going on, and then that's kind of where respiratory gets more involved. Respiratory therapy, as far as helping get rid of that carbon dioxide, is probably our biggest job to help ventilate these patients. Okay. Next slide. All right, so without getting into a whole bunch of detail with the kidney function, I know you go over some of this in A&P. The renal glomerulus filters the blood by passing water, electrolytes, and non-proteins through the semi-permeable membrane. So bicarb is filtered through the membrane, while CO2 actually diffuses in the tubule cell. And you can see pictures of this in Egan's in chapter 14, where then the CO2 then is hydrolyzed into hydrogen ions, which is then secreted into the renal tubule. Hydrogen ion secretion increases then with acidosis. So under normal circumstances, the rate of hydrogen secretion is almost the same as the rate of bicarb filtration. Okay, so you can kind of get a visual. There's some photos in Egan's. Alright, so how does this work? How does the reabsorption of bicarb work? So for every hydrogen ion secreted, a bicarb is reabsorbed. So bicarb reacts in the filtrate, forming again carbonic acid, that's that H2CO3, which then dissociates into water and CO2. And then the CO2 immediately diffuses into the cell, is hydrolyzed, and the hydrogen is secreted into the filtrate, and the bicarb diffuses into the blood. So don't get too, I mean, this is a really involved process. I think the kidneys are probably the most complicated organ in the body, to be quite honest. I remember studying this in A&P myself, and I'm like, what? So don't get, I'll let you know what you really need to know, but we're just kind of going over this here, so hang in there. So the bicarb then has effectively been moved from the filtrate to blood in exchange then for the hydrogen ions. If there is an excess of bicarb that doesn't react with the hydrogen, it's just going to be excreted in the urine. Okay, so that's how it kind of gets rid of that. So the role then of our buffers in excretion of excess hydrogen ions. So once the hydrogen has reacted with all the available bicarb, excess reacts then with phosphate and ammonia. Okay. If all urinary buffers are consumed, further hydrogen filtration ends when the pH falls to 4.5. Then the activation of the ammonia buffer system enhances chloride loss and bicarb gain. I think I forgot my 3 there. I'm looking at the bicarb. Yep, I sure did. So I forgot my 3 there. I apologize. So activation of ammonia buffer system enhances chloride loss and bicarb. There should be a 3 there. Gain. So blood chloride and bicarb are reciprocally related. When one is high, the other is low. So when we see patients with chronically high PaCO2s, which is the arterial level of carbon dioxide, which is in our COPD patients, they also tend to have a low chloride level, so hypochloremia. So it's kind of doing that reciprocal relationship. Just kind of a little side note there. Okay, so the lungs can actually get rid of CO2 in seconds, where the kidneys require hours and days to actually change the bicarb and really affect the pH. So it will happen, but it happens definitely over time. Or we can intubate somebody, and even if it's a metabolic process that's causing the acidosis, we can kind of step in and help with that acidosis until the kidneys have had a chance to recover, or whatever else is going on, if it's a toxin or something, overdose or whatever, that can hopefully then the kidneys can start to correct the acidosis by bringing up their bicarb level. So again, the CO2 can be corrected in seconds by our lungs, but the kidneys require hours or days to change the bicarb and affect the pH. Only the renal system can rid the body of acids such as phosphoric acid, uric acid, lactic acids, and ketone acids, and those are also known as fixed acids. And only the renal system can actually regulate alkaline substances in the blood and restore chemical buffers that are used with managing the hydrogen ion levels, extracellular fluids. So these are numbers that you need to know, and these numbers can help you fill out your workbook for EGAN. I think it's page 70 and 71 on the bottom of that second page. I think the first one is a matching, and then one of the last problems of that homework assignment is like a table that you need to fill that out to put the normal values in there. And before I forget, I'm going to just say this right now. Make sure, because I don't know if anybody's told you yet, but make sure you get onto on your EGAN's workbook. There is inside your EGAN's and your textbook too. I just don't have my textbook on me, but I have it electronically. Go ahead and get on evolveelsevier.com website. Okay, they're the publisher of these textbooks, and Desjardins, I believe. No, is Desjardins on there? I can't remember. But for sure, EGAN is on there. Wilkins, which you'll be using, Pillbeams, which is your mechanical ventilation book. There are many of your textbooks are made by that publisher, and get registered. You may have a code inside your cover of your book, or maybe, I don't know, I don't think they do discs anymore, but reach out to those publishers and get yourself registered. It's included with your textbooks, and the reason I'm telling you this is that it has access to other resources in there, including the answer key to your workbooks. It's under student resources. So I would definitely utilize that. I tell folks that, to do your work and then double check it with the workbook, because a lot of the instructors use the workbooks as supplemental. So get on that website and get that resource so you're registered. Alright, so again, here are these normal acid base balance numbers that you want to memorize. You'll have these memorized by the time you're done with the program. So kidneys maintain the bicarb. Okay, I've already said that 100 times. And the normal range for bicarb is about 22 to 26. Sometimes you'll see a slight variation depending on the textbook, but it's pretty much 22 to 26 milliequivalents per liter. Okay, so get that ingrained in your head. That's a normal bicarb level. And I'll just kind of say it now so you can maybe take little notes along the side. So if your bicarb is low, okay, so if you're below 22, then you're into an acidosis, okay? So it's a metabolic acidosis with a lower bicarb. And then if your bicarb goes above 26, then you're in an alkalosis. And if it's the bicarb that's out of range, then it's a metabolic process. So a metabolic alkalosis for a bicarb of greater than 26. So your lungs then are in charge of your CO2. And the normal range for CO2 should be 35 to 45 millimeters of mercury. Okay, and the opposite kind of happens here with these numbers. If you have a low CO2, less than 35, then you're going to have a respiratory alkalosis. And if you have a high CO2, greater than 45, you're going to have a respiratory acidosis. Okay, so you have this respiratory metabolic thing going on, and depending on which way the numbers are determines, and of course your pH, knowing where your pH is. So you can have a little bit of a fluctuation of those numbers, you know, like 1 or 2 points off, and then the other system will kind of balance it out. So no one's really super alarmed if you had a CO2 of like 46 and you had a bicarb of like 26 or 27, as long as that pH is still in that range of 7.35 and 7.45, because then everybody's doing their job and keeping everything compensated well. It's just when things fail due to diseases or other situations that, you know, especially interfere with breathing, that the numbers can get kind of wacky. So, so again, in healthy people, the body's buffer systems, the lungs and the kidneys, and work together to help maintain this acid-base homeostasis under many different conditions. Okay, so you want to know then your pH, 7.35 to 7.45 being kind of the happy state, and that's based on your Henderson-Hasselbalch equation. That's what the HH equation. So your pH then really is determined by the ratio of bicarb to dissolved CO2. And the normal ratio would be about 20 to 1. 20 to bicarbs to 1 CO2. Okay, so if you have a 20 to 1 ratio, you're going to have, and that's not equivalent to these other numbers. You're not going to have like 20 times as much bicarb to 1 CO2. It's just, this is just looking at keeping the pH normal here. So if you have a 20 to 1 ratio, this is going to provide a pH of about 7.4. If you have an increased ratio, okay, so you have a higher amount of bicarb, okay, so if your bicarb is that 25 to 1 ratio, then you're going to be alkalotic. And alkalotic is a higher pH. If you have the decreased ratio, okay, so your bicarb is lower, like I mentioned, bicarb low a lot of times in renal patients, then you're going to be in acidemia, okay, which is a decreased pH. All right, a lot to say there. Okay, so as we are looking at, again, at the Henderson-Hasselbalch equation, shows that the plasma pH then is determined again by the ratio of bicarb to dissolved CO2. And again, as long as the ratio is 20 to 1, the pH is normal. And I'm just going to show you kind of some different variations of how this can happen. So because the kidneys, and again, control the bicarb and the lungs control the CO2, the Henderson-Hasselbalch equation can be written kind of like this. So the pH is proportional to that little squiggly line there that, I don't know, looks like a fish, is proportional to. That's what that means. The kidney, the ratio of the kidney to the lungs. Okay, kidney control of bicarb, lung control of CO2. All right, So when we're looking at a primary respiratory issue, okay, we're looking at the CO2 is if it's going to be a primary respiratory issue. Okay, so I think I have my pages mixed up here. Yeah, I do. Sorry. I'm printing all this. Okay, so primary respiratory disturbances, your CO2 then is controlled by your lungs. So changes then in your pH are, if your CO2 is out of whack, then it's considered a respiratory disturbance. Okay, so if you think about hyperventilation, okay, so if you're breathing really fast and deep, your CO2 is going to drop. Okay, so your CO2 will drop, which will actually raise your pH. Okay, and then you become respiratory alkalosis. So if you can get these relationships down, that's probably the biggest takeaway with this lecture. So if you have hypoventilation, so hypoventilation, remember hyper being above, hypo being below normal. So hypoventilation, drug overdose, head injury where you're just not breathing, a stroke. Okay, so your CO2 is going to go up. Okay, that's not good. Your pH starts to drop, and then you become acidotic. And because it's the CO2's low, I'm sorry, your CO2 is high. Sometimes I wish I'd listen to what comes out of my mouth. If your CO2 goes up, then your pH is going to drop, and you look at your blood gas, because we draw blood, and the CO2 and the bicarb is part of the values, and the pH. And if we see that our CO2 is high, let's say, so we have 35 to 45, and we get a patient in and they haven't been breathing, whether it's a cardiac arrest or whatever, and their CO2 is like 60 or something, then their pH is going to be, maybe like 7.25. And if they're not awake and alert, then we're going to have to intubate them. Okay, and then they are in a respiratory acidosis. So that is probably our biggest time that we intervene. It's a respiratory acidosis. Okay, it's the lungs' fault. The CO2 is high for whatever reason, whatever happened to that person, and now they're become acidotic, and especially if they start drifting below that 7.35. So, I mean, there's a lot involved. It isn't just hard and fast numbers. There's this whole situation. Okay. So I went ahead, I hope these turned out all my little arrows, inserting all these arrows. So this is how I was trying to explain here the relationship of these numbers. So if you're looking at respiratory disturbances, okay, and you're looking at that Henderson-Hasselbalch equation with the ratio, okay, and we'll be talking about ratios here in math soon. So we have the bicarb on top and the CO2 below. Okay, so we're going to just keep it that way. So our pH is proportional to that ratio of bicarb to CO2. Okay, so this is showing that what's going on here is with the respiratory disturbances, it is going to be the denominator that's going to be affected. Okay, so respiratory disturbances affect the denominator of the Henderson-Hasselbalch equation. Okay, so the denominator is going to be changing. It's either going to go up or down. Okay, so if our pH goes down, that's telling me I'm acidotic. That means my CO2 is going up. Okay, so that's a respiratory acidosis. So on the flip side, so the straight line there for the bicarb just means it's unchanged. The bicarb is just staying there. Okay. So on the flip side of that, my pH is up, my CO2 is down. Okay, I'm overventilating for some reason, and that can sometimes happen when patients are on a mechanical ventilation. Then it's a respiratory alkalosis. Okay, now we're going to kind of look at a metabolic disturbances affect then the numerator. So in this part of when we're looking at the Henderson-Hasselbalch, the CO2 is going to remain unchanged. It's the numerator that's going to be affected. So So that's affecting the numerator. So that's either going to be up or down. So when we're looking at, so if you put these two things next to each other, you can see it's kind of flip-flop. So for pH again to be down in acidosis, the bicarb has dropped. Okay, so you have a low bicarb, and that's going to represent metabolic acidosis. And then vice versa, if your pH is up, your bicarb is up, then you have a metabolic alkalosis. And as we go through the program, we will be talking about different causes of these disturbances. All right. So, primary metabolic disturbances. So, again, involve gain or loss of fixed acids or bicarb, which involves the kidneys. So I'm just kind of repeating it, but just in a different way. Decreased bicarb results in metabolic acidosis. Increased bicarb results in metabolic alkalosis. Okay, so when you're looking at blood gases, basically, and you're interpreting them, which you'll get plenty of practice to do this, you're looking at the pH. Okay, so you're looking to see if it's in range. Are you in between 7.35 and 7.45? If you are, then all is pretty good in the world. But if you have a pH greater than 7.45, that's telling you right there you're alkalotic. And if you have a pH greater than less than 7.35, then you're looking at acidosis. So then you look at your CO2 and your bicarb levels to see, is it respiratory component or is it metabolic component? Okay, and then checking for compensation. Did the non-causative component respond appropriately? So did you have a respiratory acidosis, your CO2 is high, have your kidneys responded? Chances are no in an acute process. Okay, acute meaning that something has happened immediately, that's happened very quickly. The kidneys don't have much of a chance then to do anything. It'll correct itself over days, but by that time you might be dead or getting sicker. So so you kind of look to see, but if you do have, so this is just again a side note, I tend to talk too much, but so when I'm talking about those COPD patients that have a higher CO2 over time, their lungs are kind of getting shot and they're not able to participate in gas exchange as much, so they kind of live with a higher CO2, but they're happy because their bicarb over time has increased and it's compensating for so they're not acidotic anymore. But there's a thing called an acute on chronic. Okay, so we have exacerbations of COPD, and we have a lot of patients. Those are a lot of our patient population. Our COPD patients that get sicker, they get a bad bronchitis, or their COPD just happens to get worse. It even can be an upper respiratory infection that just kind of leads to bronchitis. They get a pneumonia. So they have a high bicarb to help compensate, but their CO2 is even higher now. Okay, so when we look at those patients' blood gases and we see that they have a higher than normal bicarb and they have a smoking history, we know that they're a chronic patient, but now their CO2 is even higher. Their body can't compensate for that acidosis. So a lot of times we try not to intubate those patients. We try not to put them on a ventilator because they're really hard to get off of a ventilator, but we'll do something what's called non-invasive ventilation with BiPAP, and you'll get to learn a lot about that. So we have a lot of tricks up our sleeve that we can do to kind of help these patients get through their acute process of whether it's a pneumonia, bronchitis, whatever's going on. So, all right, sorry, got a little carried away. I get excited. Okay, so what we really want to do, our goal is to try to get that pH to that normal, back into that normal range of 7.35, 7.45. Okay, so any primary disturbances immediately does trigger a compensatory response. However, keeping in mind a respiratory disorder is going to hopefully be eventually compensated by the kidneys, but it can take hours to days. Okay, But a metabolic disorder can be compensated by the lungs, and that's generally, your body can do so much. So keep in mind, your body can do so much, and then sometimes it fatigues, and you get tired of your breathing, gets tired, you get labored of trying to compensate for whatever's going on metabolically. So that's another time where we have to step in. I'm so excited for you guys to learn all this stuff. I know it just is really heavy right now. All right, so again, I'm just kind of putting this down in different formats, I guess. Remembering respiratory acidosis, hypoventilation, you're not breathing that well, okay? Hopefully your kidneys are going to hold on to that bicarb and help compensate and help get that pH back to normal, okay? If you have a respiratory alkalosis, okay, you're hyperventilating, you're breathing off too much CO2, and now your kidneys are going to help eliminate bicarb because you don't want too much bicarb, you don't want that buffer, you want to try to get your pH to normal, okay? Metabolic acidosis, okay, a real common is like sepsis is metabolic acidosis, renal failure. You're hyperventilating, you're decreasing your CO2, you're bringing it down because you're trying to help get that pH back up, okay? And then metabolic alkalosis, so your bicarb level is high, so you're going to hypoventilate. You might slow your breathing down, increase your CO2, which then helps offset by lowering that pH. All right, so your equation, again, that I'm referring to is your carbonic acid, your CO2 hydration reaction, your CO2 hydration reaction. Okay, so that is a large portion of the carbon dioxide is transported then as bicarb, and as the CO2 increases, it also increases the bicarb to act as a buffer. So for an acute increase in PCO2, the plasma bicarb increases approximately 1 milliequivalent per liter for every 10 millimeters of CO2 rise when your CO2 gets above 40. So for an example, an increase in CO2 of 30, I should put millimeters of mercury there, would actually increase then your bicarb by about 3 milliequivalents per liter. So if your CO2 would increase, let's say from 30 to 60, your bicarb may go up from 24 to 27, okay? But again, keeping in mind that takes quite a while. Okay, I know that's a lot to bite off, but we'll get through it a little bit at a time.